So the final talk of the morning will be Professor Ron Kessler.
Thanks very much. I didn't plan it this way, but it's really interesting to know that I'm the only person who's spoken so far who's not a clinical psychologist. And most of the people, a big theme that's related to Alan's work is kind of getting outside the lab and going out and doing, sort of thinking of big interventions. So it's only fitting that as an epidemiologist, I find myself in my later years turning to doing clinical research, which is an interesting thing. Now, the inclination that has been described here in the other direction is kind of a natural one. That the epidemiologists always talk about the difference between a clinician and an epidemiologist as being kind of the guy who's walking down the riverside on a sunny day, and all of a sudden hears somebody say, "Help, help, help," and he looks and he jumps in and he pulls them out and gives them artificial respiration and saves their life and feels good about himself and starts walking again, and 5 minutes later there's another help, 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 and you jump in the thing and you kind of spend the day doing that, and you say, "I'm so busy pulling people out and saving their lives, I never have time to walk upstream and see who's pushing them in." And and that's kind of the difference. At a certain point, you got to decide where you want to go. At the other side, though, and it's interesting that at a certain point, there's some people who clinicians get burnt out, who take the leap back and say, "I want to make some structural changes. I don't want to help one person at a time. This is ridiculous. I'm helping one and there's 50 coming in the door," kind of thing. At the other side, though, I have some friends who are epidemiologists who in mid-career went back to medical school, because there's this way in which you stand back and you're doing stuff for the world, but you never quite are sure if it's going to make it there or how many years it's going to take, and there's sort of an appeal to being able and say, "I helped this one person today," and so there's these kind of two tensions, and it's natural that at a certain point in your career you find yourself wanting to go in the other direction, because there's obviously a pull in both directions. So I haven't given up epidemiology, but in the last few years I've been dabbling with doing work in precision treatment. And when I say precision treatment, as I look more, and I should say that my training is in sociology, not in psychology. I never took a psychology course in my life. My wife is a psychoanalyst, though, so I mean, it's interesting. When I talk to her, she has 3 patients. I have like 200,000 I work with, or stuff like that. It's a little different, but there is some clinical stuff you do. I mean, there's some intervention sort of stuff you do at this level. So when Kelly was talking, I was thinking of work I'm doing with in West Virginia, which, as you might know, is the opioid death capital of America, and about 2/3 of people who are opioid addicts become addicts starting by taking a medication because they have a pain condition, and then they never stop. And the question is, can you start people, can you figure out who those people are at high risk and do something else? There's some people who just need an opioid. That's all there is to it. They've had cancer, things like that. And there are all kinds of subtle clinical interventions you can do that have been tried. The thing we're doing is we tell doctors that you're not allowed anymore. There's a law. You can't write a prescription for more than 7 days. So if you write a second prescription, you have to see the patient again. Opioid abuse has been cut by 45%. Not a deep psychological insight, but an interesting kind of stuff that makes a difference. So when I first started thinking about this stuff, and I'm going to tell you a little bit about how I got involved in doing this, but I want to, before doing it, say something about Alan, which is that I think this stuff we're doing now is really interesting and important, and we've been doing it for a couple of years. And when I first thought of doing it, going into doing clinical work, I asked Alan about it. What did he think about this thing? And he in his sage way said, "Don't do it." And fortunately, This was a couple years before his retirement. I never had come to. As I said, I'm not a psychologist. He's just a friend of mine. Haven't looked at his work as much as you. So I didn't know how distinguished he was. So I totally ignored what he said. So it worked out well. But thank God, it's just order of operations is really an important thing in a lot of stuff in life. So anyway, we're doing this stuff, and moving to opportunity, MTO, is a study I've been involved in for many years, again as an epidemiologist, but it was a clinical sort of a structural intervention. Some of you might have heard of it. MTO is a study that started out with about 10,000 low-income families in inner city housing, like Cabrini Green in Chicago was one of the sites, stuff like that. And we worked with HUD, and they were randomized, a random 50% of them were given a voucher to get a house in the suburbs and to see what effect does it have on their lives. And we expected that it would have a different effect for kids of different ages, which it did. If you're younger when you move out, then it has a bigger. When you're 12 years old, you're the official juvenile delinquent because you came from the inner city kind of stuff. But it turns out there are a lot of things differ. So it was a very good intervention for girls, little black girls who were sort of adopted by the teachers, and you poor thing. But the little black boys were sort of defined as a problem kid and extruded, and it turns out it was really a terrible thing. Things were worse for them than if they had stayed in the city. And you start realizing there are a lot of things that are these big group level interventions where the effect, which was on average not very big, was substantially greater if you think about not effects on the average person, but effects on targeted subgroups of people. And when you think about effects on targeted subgroups where there's a bad effect, although I, in my epidemiological wisdom, don't have any great ideas about insights there, when somebody says, oh yeah, boys get treated this way, well, there's sort of things you can think of to make the intervention actually work for them, because there's other kind of supports you need to build in and stuff to change the intervention, which is the kind of stuff psychologists do, look at process sort of stuff. So I thought, well, gee, that's interesting. That's sort of an interesting way in which structural kind of things you can think in terms of differential treatment response rather than average effects. In the Army STARS study, which I'm involved in and Matt's involved in too, which is a big $100 million initiative from the Army and DOD to study suicide among military people, we're looking at things like the obvious thing to look at, given that the suicide rate has been rising pretty dramatically in the Army since the beginning of the Middle Eastern wars, is what's the effect of deployment. And it turns out it's not an obvious thing to be able to study, because people don't get assigned randomly to it. There's a lot of selection bias out. People who are the worst people never get deployed. There's this sort of healthy worker kind of thing. And in addition to that, we're coming to realize more and more that if you're going to fight a war, you have to have some people who go to the war. And the trick is not to be able to say what's the average effect, but again to be able to say who are the kind of people who have the multivariate profile to begin with, who could do okay in that situation, and who are the ones that are not. So you find yourself thinking in this, what's now become talked of as the precision treatment kind of thing. It's a different idea of what a treatment is. It's an intervention. The intervention is go to war and be exposed to all this terrible stuff. And are there some people who can deal with that okay and some who can't? And then more recently my work with Reach Vet. And Reach Vet is this program that the Veterans Administration has. As you probably know, there's 20 veterans who kill themselves every day. Matt says you're not supposed to say kill yourself, say die by suicide per day. And that's about 1 out of every 6 suicides in America is a veteran. And there are about 12 million veterans in the VA health system. And the question is, what do you do about that kind of thing? There's all kinds of places, thinking of that river analogy again, how far you get down the line, where you intervene between not letting them be a veteran because they don't bring them in to begin with, or doing some early intervention to build resilience and so forth. But to make a long story short, we've been working on machine learning models to be able to pinpoint the small number of these people who account for the high risk, concentration of risk. So we can find about 5% of veterans based on not just things about their health care profiles, but also things about where they live and their military career kind of stuff and what experiences they had in the military and so forth. But the 5% of people who, according to our model, have highest risk account for about 40% of suicides. So you have this, what's called in the machine learning world, lift, a high lift. And that means you have this small number of people that have high enough risk that maybe your positive predictive value is enough that you can have a positive return on investment. So we've developed these models, and the VA has now is created this program called ReachVet, which is using the statistical models we've developed to target a small group of veterans at very high risk for preventive interventions. Now, what those interventions are, fortunately, as I said, I'm the epidemiologist, so I can say to the clinicians, there they are, go get them, good luck. I don't have to worry about what the interventions are. But there is some interesting stuff of trying to sort of figure out, once you say there they are, is there some guidance you can say about what's their issue? We're doing other stuff about that, which I won't talk about today. Which actually I talked to you about in another context with that AJ thing. I wrote you. But the thing that's interesting about it, when ReachVet was done, and ReachVet's a big program. It's about 30,000 people get intervened on every year since 2016 at a cost of over $1,000 per person. So we're talking about $30 million intervention a year with no intervention, with no evaluation. And the reason is it's 100% of the people above the threshold. There was nobody wanted to randomize anybody because for political purposes they didn't want to have somebody who died, who had a coin flipped, and their wife says you got them in the control, so it's above the threshold. But the thing that's tricky, and again, this is from an epidemiological perspective, the people who are at the highest risk of killing themselves, pardon the term, are not necessarily the people who are the most likely to profit from an intervention. So if we wanted to reduce weight, we wouldn't take all the people. I can tell you all the people who weigh 500 pounds. But going and trying to get those people to lose weight is not the way to prevent the most heart attacks and strokes. I mean, there's data on this. You go after the people who are 210 pounds and you get them to weight 180 pounds, and per dollar spent, that's the way to prevent the most heart attacks and strokes. And it's a similar kind of thing here, that you'd like to say, who are the people who are going to profit most from the interventions that we have available? Is there some epidemiological way to inform clinical decision making to try to do the most good for a inevitably fixed amount of money and fixed set of ideas that you have? And we're starting to think that through, because the clinicians who think about treating one person at a time are not doing a very good job of it. So let me give you a good example is, sort of alexithymia and psychotherapy. There's certain kinds of psychotherapy that don't work for people who have alexithymia. It takes about 3 minutes to administer an alexithymia test. You've got to score above 13. There have been studies that show the intervention is zero effectiveness. And I spoke to David Shulkin about this, the late departed David Shulkin from the VA when we first started doing this work, and they're funding us now. And I said, given that IPT kind of stuff that doesn't work with people with alexithymia, how much is VA spending a year on IPT? And they have these kind of manualized kind of things. They're actually pretty good at that. People get trained and certified. And because there's going to be a high rate of alexithymia in the VA. And he said, I'm not sure exactly. And I said, I am, because I looked it up before talking about it. I said, it's $50 million you're spending a year on alexithymia. My rough guess is that 25 million of it, you're just pouring the money down the drain. So I said, how about this? I'll split the difference with you. You give me 12.5 million. You keep 12.5 million. We'll figure out a system where everybody has to have a series of these things administered to them before they're allowed to be paid for this. Now, it's not that the therapist is a bad person, because they only know how to do one thing. These social workers, they train in IPT and they believe in it and stuff like that. And they met Myrna Weissman and they shook, all that kind of stuff. And they've helped people in the past, so they know they can be helpful. But you don't have that. having a perspective of what's the best thing to do, they don't think about other things that can be done and what's the most cost-effective thing to do. So that's a stark example, but in most cases, there's not just one thing that's important. There's a whole bunch of things that we know to be important. And that's the kind of stuff that we're looking at in this initiative. So what we know now is this. There's a great deal of work that's being done on precision treatment of mental disorders, most of it in biomarkers, and we know that biomarkers aren't strong predictors. We know that many psychosocial variables are strong predictors, but the existing studies of psychosocial predictors are limited because they're mostly small sample sizes. 75 people get psychotherapy and 75 get psychopharm, and they find that women respond better to something or other and people with high IQs, and they sort of, and there's 3 variables in the model, and 2 of them are interactions, and then there's dozens and dozens of these studies. And there are some, and they usually focus on 2 treatments that are usually not the same treatment. Sometimes it's called psychotherapy, this thing called psychopharmacology. Sometimes it's CBT and something or other. Sometimes it's CBT version 1 or version 2, or if in David Barlow's place, it's CBT version 1.305 versus 1.30. Sort of. So but there's not accumulation of evidence about this kind of stuff. So what we really need is to be able to gather up all this information, have comprehensive batteries of the things that we found to be significant predictors, and put them in to begin with in very large samples, as it turns out, and be able to do fancy kind of models that can look at differential treatment response. Now, it turns out, I'll show you very quickly some data in a couple of minutes, that you really need large samples to do this stuff. And a big problem in this area is that nobody's done power calculations. And I'm going to show you in a minute some power calculations based on a state-of-the-art kind of fancy ensemble machine learning method. But the bottom line is you need about 500 people per arm to be able to do this stuff. Clinical trials are not being funded for 500 people per arm. So the solution is you really need to begin with observational clinical studies rather than RCTs. Rich baseline, web-based, self-report questionnaire, and web-based neuropsych assessments, large samples that can be obtained quickly and inexpensively doing this kind of stuff. And you deal with the issue of non-random assignment by doing quasi-experimentation, double robust estimation for people who know that kind of stuff, and second stage pragmatic trials. So we're right now in the VA and also in a commercial health plan. The VA treats 500,000 people a year for depression. 10,000 a week, 2,000 a day. Every morning, we get 2,000 records for people who have not been in treatment any time in the last 12 months that we know they just started treatment for major depression. And they're in different parts of the country. In some places in the country, there's no psychotherapist, so they're getting medication, that's it. And if they're in another place, they have the option. And, depending on the kind of clinic, we know what's available. For people who have medications and they see Dr. X, who happens to be 65 years old, they're getting Prozac. Because I've seen Dr. X's record, and the last 200 people he's treated for major depression, this primary care doctor, 197 of them he gave Prozac. Whereas this 32-year-old doctor, they're giving second-generation SNRIs or so. Yeah, I mean, but so there's some stuff that's quasi-randomized that you can use these as instrumental variables and try to build up something that gets close to experimental control. But you obviously don't have experimental control. I won't go into the fancy statistical methods of doing the analysis, but in that first stage thing, you can get pretty large samples. We're right now, over the next year, building up a sample of about 5,000 people who are being treated for depression at a relatively small cost, a couple $1 million. It's not like some ridiculous amount of thing. Building models of that sort, if you can say, in terms of simulation, it looks like if you were, instead of just letting the doctors do what the heck they want to do, or the social worker or whoever, if you were to optimize treatment by having this person get that treatment and this person get that treatment, instead of the roughly 30% of people who remit, we think we can make it close to 70%. Well, when you go back to 500,000 people, 30% remitting, of this other 70%, 50% come in for a second course of treatment. Of those, only about 20% remit. Of the remaining, that third course of treatment. Around that time, these are low-income low education, relatively young men, they give up and they kill themselves at that point. So you have sort of 3 shots. And figuring out what the right treatment is for the right patient right away is really the trick here. Realize that you have 3 chances, pretty much. So if you were to do something like, say, PTSD Coach, which is a very inexpensive, essentially self-help manualized thing for people with PTSD because you're waiting 6 months to get in treatment. That's not, why not? And it's given out like candy now in the VA instead of a waiting list, right? The reason why not is it's not going to work for very many people. It's frustrating as hell. And you just used up one of your 3 degrees of freedom. You set 85% up of people for failure experience. And you've gotten them that much closer to killing themselves. So being able to figure out how to optimally target the right treatment for the right person is really the trick. And even though what I'm talking about so far is not experimental, the next phase is experimental. And it has to do with pragmatic trials, which is to say, again, for a relatively small amount of money, we're now working with a number of VA facilities who've looked at this and said, God, this really has the potential to do something. So for them, we're setting them up and saying, how about next year, we're going to keep doing it, and a random half of the patients, we will, at the time you start treatment, give you feedback and say to you, here's what our actuarial models say the right treatment is for this person. Do what you want to do. But we have a case manager who can consult with the clinician, and we sort of push them in the direction of a thing. And using that as an instrumental variable, we can, again, very inexpensively evaluate what the impact of essentially intervening with better information about how to guide people to go in the right direction. And it's, as I say, it's an epidemiological perspective rather than a clinical perspective, because we're not looking at the precision of the treatment. We're looking at the precision of the patient. Who's given this black box called X treatment that we can sort of define in some relatively well-defined way, even if it's just psychotherapy, psychopharm, both, and we know that there's sort of 30% recover, 50% recover, and then go inside of each of those, we can do a lot of good in that relatively fuzzy but relatively distinct thing in getting people in the right direction, essentially in a cost-neutral way. Don't give treatment A to this person, give it to this people. Don't give B to that one, give it to that person. So you're not really changing the amount of money of the intervention. You're just moving the system around in a clinical decision support way to help people get from here to there. So now that you're retired, you get to come up to Boston and you can work with us on this stuff. I hope. Okay, Alan, it's been great working with you over the years. I hope we continue. Maybe with this, who knows? Stranger things have happened. Thank you very much.